about the ILLUMINATE study. It's basically efficacy and safety of Durvalumab, Tremelimumab with chemotherapy in EGFR mutated lung cancer who has progressed on EGFR therapy. So to sort of give a background, EGFR TKI is we all know are the standard for EGFR mutated lung cancer, but majority of the patients will develop a resistance mechanism and they will eventually progress. We have the most common option to use is the platinum doublet chemotherapy, but they have short limited response rates and we need other options. Multiple meta-analysis or retrospective studies has shown that anti-PD-L1 antibodies have a limited efficacy in this particular subgroup, and the addition of anti-PD-L1 antibodies have not shown any benefit in two big phase 3 studies recently, didn't show any benefit of adding immunotherapy. So basically, this study was done to combine anti-PD-L1 and anti-CTLA4 antibody because they have complementary mechanism of action and they were sought to have more potent immune response in this subgroup. So study aim was to evaluate the efficacy of this combination along with chemotherapy pre-treated patients. My hypothesis was that dual blockade, this dual immunotherapy will be more tolerable and superior to just giving chemotherapy or a chemotherapy plus a PD-L1 inhibitor. So study design, basically EGFR mutated lung cancer, patient has progressed on EGFR TKI, have not received any previous chemotherapy. There were two cohorts. First cohort was T790M negative, 50 patients were there, and second cohort T790M positive mutation was there, and the patient has progressed on third generation TKI. So basically induction of a doublet immunotherapy along with chemotherapy was given for 4 cycles, followed by maintenance of Durvalumab plus pemetrexed. The primary outcome was overall response rates. So around 100 patients were there in the study, majority were females, majority were Asian patients, slightly more exon 19 as we all know. Around 50% of patients were PD-L1 positive and 50% of patients have received more than one line of TKI prior to this trial. So we look at the overall response rates. Confirmed response rates were 31% in the first cohort with T790M negative, slightly lower 21% in the T790M positive cohort. We see majority of the patient has responded. Spider plot shows that majority of the patient had a response. Overall disease control rate was around 88% in this study, including both the cohorts. But the durable responses were seen more in the patients who were T790M negative rather than T790M positive. Similarly, we see the responses were more durable in the T790M negative cohort compared to the patient who had that resistance mechanism. If we look at the different subgroups, responses were seen irrespective of most of the subgroups, whether the patient was young or old, current smoker, former smoker, Asian, non-Asian, whether any kind of mutation, exon 19 or 21, PD-L1 though less, didn't make any big difference between the two cohorts in regard to the response. We look at the PFS in this cohort, both the cohorts. In PFS in the cohort 1 was around 6.5 months, in the PFS in the cohort 2 was 4.9 months. As we all know, T790M positive patients don't do that well. So looking in the cohort 1 patient who were patient negative, PD-L1 positive patient actually did well. Patients with PD-L1 more than 50% had a median PFS of 13 months compared to 5 months in who had a PD-L1 less than 15%. But it was sort of opposite in the cohort 2 with patient with T790M positive, PD-L1 high. Patients didn't do that much well, a PFS which was reversed of 5 months versus 13 months. But the safety about the use of immunotherapy, how well works with the combination and all. No any new safety signal was seen, no significant grade 3, grade 4 difference was between the two cohorts. Treatment discontinuation was there in 6 patients because of the immune-related adverse events. So to basically summarize, this combination has shown a modest anti-tumor activity in this EGFR mutated pre-treated patients. There was slightly numerical benefit in response rates and PFS in patients who were T790M negative, and safety profile was more or less consistent with other immunotherapy regimes we have been using. But we have to understand that we now have 2 phase 3 studies with Durvalumab and Tremelimumab to show any benefit in this particular subgroup. And these are sort of early data, so now maybe with a combination we might have some subgroup which might benefit. So this was a nice review in Nature. They have shown that what kind of resistance mechanisms it develops and what can we do to target those. So basically, if we better select the patient, we might get more benefit out of PD-L1 therapy. Thank you.